presentation about statistics. I know a lot of my colleagues tend to struggle with some of the concepts here, so I just thought I'd run actually quite a short session on the two main things that tend to come up in OSCEs. Now, previously when I'd run the session, we used to put people in like breakout rooms and get people to like practice some of the scenarios. But because of the new format, I think what I'm going to try and do is just run through the stations together here. Please do unmute yourself. I think everyone could unmute themselves and like interact with me or post in the chat, because I will have the chat up here to the side. That's why I keep looking to the side. I have the chat there just to make this interactive. The other thing to note is, despite my fancy title, I'm a medical student. Can you mute yourself? Yeah, cool. I am still a medical student, while the statistical bits I think I'm quite knowledgeable about. Some of the OSCE tips that I'm going to give are just my own sort of opinions, so just bear that in mind. So in this presentation, I'm just going to go through some basic sort of quick bits and bobs that you need to know. And then we'll go through the two main stations, which is the survival curve or the Kaplan-Meier curve and the forest plot, which are the two stations that tend to come up in OSCEs at George's. If you go to a different medical school, it might be that you can get something different, or maybe the structure of the station is going to be different for you, but still the statistical concepts that we're going to describe are still going to be relevant and probably useful for you. And also just moving forward in your careers as doctors, being able to understand research papers is like really important. So yeah, this is the first bit. So in George's, a lot of people tend to fail or do pretty badly in the stat station, and like the average grade tends to be quite low. And I think there are a couple of reasons for this. And at least at George's, one of the big things that trips people up is that the station has a completely different structure to the normal stations. So at George's, we get, especially in third and fourth year, 10-minute stations. And so when you're practicing information giving or taking a history, you start sort of training yourself to be able to do all of that in 10 minutes. But the statistics stations don't work like that. The actual station length is 8 minutes. And when you first go into the station, you're basically told to sit down at a table for 2 minutes to look at this table, this graph, this data that you have to interpret, during which time you're not allowed to talk to the patient. And then after 2 minutes, the examiner will say, okay, you may now start speaking to the patient, and that throws people off because they haven't practiced it at the correct timing. The other thing is stats tends to be quite poorly taught to medical students, and even like foundation doctors and even more senior doctors don't really understand stats that well. Before I became a medical student, I actually ran a medical statistics course for AFPs at Royal Brompton, and it was quite surprising how little understanding people tend to have about the core statistical concepts, even though they were able to interpret sort of data and papers quite well. Finally, the other thing to bear in mind is that these stations tend to be communication skill stations as opposed to anything else. And people tend to sort of focus on just talking about the actual data and not doing all of the communication skills sort of bits and bobs that they expect you to do. So in terms of the actual stats you need to know for these stations, you probably don't really need anything more than just basic GCSE level sort of stats knowledge, averages, percentages, ranges, these kind of things. And just a bit of appreciation of how research works, what p-values are, what positive and negative predictive value are, these kind of things. And these tend to be taught in like first or second year of medical school. So just refresh your mind on these concepts and make sure that you fully understand them. And then we come to the two main sort of data aspects, which are the Kaplan-Meier and the forest plot, so the survival curve and the meta-analysis. And I think for me, some sort of easy ways to learn about these stats bits and bobs. I'm just giving you some suggestions. This book by Harrison Taylor is really good, and it's a very simplified text in terms of how to understand all the stats you'll need for medical school and sort of your medical career. There's this very basic looking statistics website called Statistics How To. It looks like it was made in like the 90s, but it's just got a very simple explanation of all the things, like the difference between odds ratios and risk ratios, what p-values mean, etc. Obviously, I'm going to self-plug myself. I did do a SBA session with QuesMed here on Study Hub, with all the sort of top medical statistics you'll need for finals. So do check out that video on their YouTube channel if you can. And always, if you see a term or a statistic that you don't really understand, you can always just Google it. It's quite helpful. So I'm going to go through the Kaplan-Meier curve and the forest plot, and then we'll run through the scenarios. Roy's asking, is this mostly T-year stuff? So T-year is third year at George's. Kaplan-Meier and forest plots mostly come up in T-year, but it is useful knowledge for all years throughout medical school. But yeah, the Kaplan-Meier and forest plots normally come up in T-year. So yeah, this is the Kaplan-Meier curve or the survival curve, and I just want a sort of yes or no on the chat of whether people know the basics of this, or do you want me to go through the whole thing step by step? Because I don't want to assume that you guys know stuff that you don't. Go through it. Okay, fine. So first of all, don't be intimidated by this graph. It looks complicated, it looks scary, but at the essence, it is the... Okay, I got it. Everyone's saying go through it. I will do. It's just a comparison of two or more things in relation to a particular outcome. The classic example you will normally see is that it compares two treatments. You know, it might be chemotherapy or surgery in cancer, or it might be two different types of surgery, and the outcome is survival. That's why it's a survival curve. So the first thing to note is that here at the bottom we've got time on the x-axis, and on the y-axis we've got survival. So everyone starts off here at 1. Sometimes it will say 100%. It's the same thing. And then as time goes by, people start succumbing to the disease, basically passing away. And what you're comparing is to see whether people on treatment A or treatment B do better. So for example, if we look at 12 months, so this, it probably should say months, but I'm assuming this is months. At 12 months, we see that around 85% of people on treatment A are still alive, and maybe about 95% on treatment B are still alive. So that's kind of all it's doing. And many more simple survival curves will just have two lines without all of this extra fancy stuff. And if we take it, further down, let's say 36 months, we can see that about 40% are still with us on treatment A, and maybe about 75%, 75% are still with us on treatment B. So overall, the picture we get from this survival curve is that probably if you were to have cancer and you had to pick between treatment A and treatment B, you'd probably go for treatment B because people tend to do better. Now, there's a lot of other stuff on this graph which may or may not be useful information for the patient, but it's really good to sort of understand what they all mean. But before I get onto that, I want to make sure that everyone understands the basic gist of it. Is everyone with me so far? Great. So other things that are on here, I just want to talk about the line a little bit. And you can see these little lines at various data points. Now, these are called error bars. And what these represent, well, it depends what program they use to make this graph, but normally it represents a standard deviation, which means that in statistics, we sometimes give ourselves a margin of error to kind of make our opinions a bit more valid. So what this says is that we think that the real number is, here at 80%. Well, there's a chance it's a little bit more up or a little bit more down. And the standard deviation represents that. And what they're doing here is that they're adding these error bars to show that even if we account for some variability in the data, we're still fairly confident that there's no overlap. Whereas closer here, we're not 100% sure because the error bars overlap. Okay, so don't get confused by these little bars here. For the purposes of OSCEs, you can just ignore them. The other thing that sometimes confuses people is this data censoring these numbers in the brackets. And what happens with this is that if you can imagine that you're running a trial of cancer patients undergoing therapy, not everyone comes back to the follow-up appointments to see how they're getting on, or sometimes people will pass away and we don't quite know at what time point they died for various reasons. And that's why we have like this censoring of data, which means that we've removed certain participants in the study to make sure that we don't inaccurately represent the data. So it's just think of it of people dropping out of the study, and that's what the censored number in the brackets here mean. And obviously at the various time points. So I guess here they're measured at 12, 24, 36, and 48 months. The other thing to note, the p-value just represents the statistical power of the study. So the smaller the p-value, obviously, normally we have the 0.05 threshold for significance. What this is saying is that the p-value is really, really small. Therefore, it's quite likely that this data is representative of the overall population and we're quite confident that it matches reality. So is everyone with me so far in terms of how to interpret the survival curve? Is there anything that anyone would like me to go over again, or things that people don't understand? Please just pop it in the chat. Okay, so I assume everyone's good with that. Number censored. Okay, so number censoring, which is here at the bottom, this number in the bracket, what that represents is people who have basically dropped out of the study, so they're not being counted anymore. And the reason this might happen is either they just don't bother to come back to the follow-ups, or if they do die and we don't know when they died, we can't accurately pop them like somewhere along the timeline, or something like that, or the records are lost, something like this. So the number censoring just means people who are no longer being counted in the study at that point. Right, well, since there's no other questions, I'll move on to the forest plot. So the forest plot is another one that can just appear a bit intimidating. And I've actually taken this this forest plot from my friend Sedgwick. It looks intimidating, and sometimes these forest plots can actually not, like this one only has 4 studies. Some of them can have 10, 20, 30, and then you get a really big plot, which can seem nonsensical at the start. But I'll just tell you what you need to focus on to just interpret this quickly for the OSCEs. So the gist of everything is this line here that says total. Okay, this total represents the overall result of the meta-analysis. So the reason we produce forest plots is because sometimes, if you remember the levels of evidence for treatments, obviously you've got empirical, and then you've got randomized controlled trials and so forth. The highest level of evidence for a treatment or for a specific association for a risk factor is always a meta-analysis, where you take many different studies and pull all of their results together to make an even stronger overall result. And the overall outcome of this meta-analysis is represented in this row here that says total. So all it's saying here is that if we put, okay, let me just explain what they're comparing here. They're comparing antibiotic treatment or appendicectomy for the cure of, someone with appendicitis. And the overall result here is represented in this little graph here. So for each study has a line and a box. And this line in the box is plotted against the risk ratio. Okay? And this here is the risk ratio. And what we want is for the risk ratio to not be 1. Because if the risk ratio is 1, what that means is that there's no difference between the two treatments. Okay? So just to repeat that a bit more clearly. Risk ratio compares the outcomes of two separate interventions, in this case, antibiotic treatment and appendicectomy. If the outcome of the risk ratio comparison is 1, or the standard deviation, which is this line similar to the error bars, intersects 1, that means that we can't confidently say that one is better than the other. So in our 4 studies here of Vons et al. In 2011, Erickson et al. In 1995, etc., we can see that actually their lines intersect this number 1. So all of these 4 studies were basically inconclusive. Obviously here we've got the number of participants and the weighting and all kinds of other statistics that don't really help us interpret the graph. But when we put all of the data from these 4 studies together, then we can see that the overall result represented by this little diamond doesn't touch number 1. So what we've kind of done is we've almost kind of like cheated by taking the results from 4 inconclusive studies and made one super study which did have a conclusion. Does that make sense to everyone? Hopefully everyone's with me, because I know there was a lot of information that I just went through there. Okay, so excellent. Okay, everyone's with me. That's great. So the point here is that by putting together multiple studies, we increase our statistical power. And what does statistical power mean? Statistical power means that our sample, when we've taken a sample of the overall population, that sample is more representative of reality. Okay, and in simple terms, the more people we sample, the bigger our statistical power. And that's why putting together the data from multiple studies increases our statistical power. So here at the bottom are the test statistics of the meta-analysis. You can kind of ignore the test for heterogeneity. That's a bit nuanced and not really at undergraduate level. But the main things we want to identify is this p-value here. If this diamond does not touch the number 1 line, then this p-value is going to be less than 0.05. And as we can see, it is. So you can either look at this little box here and look at the shapes and stuff, or you can just go straight for the p-value for the test of overall effect. So with this knowledge of this p-value, this little diamond, and the fact that this diamond is in the side that favors antibiotic treatment, the overall suggestion of this meta-analysis is that actually antibiotic treatment is better and has better outcomes than appendicectomy, at the very least in this population. Now, that's really all you'd be required to interpret in an OSCE station in the 2 minutes you have. And probably that's all you'd be required to explain to a patient or a simulated patient who's going to be in the station. Now, if people are interested, I can explain the other test statistics here and what these all mean, but I'm not sure if that's going to be useful information for you guys. If people want me to explain it, just say in the chat. Explain the test for heterogeneity. Okay, so when you're putting data from different studies in one, so think of it like big Excel spreadsheets. Now, I'm not sure if you guys have ever had to fill in Excel spreadsheets, or your uni. Well, I know my uni makes me fill out this core thing, but the point is that when you're putting data together, sometimes the format of the spreadsheet isn't going to be identical. So you can't just copy paste data and just pop it into your big table. Sometimes the columns or the rows, so like the variables, are going to be different. Maybe Vons and friends only picked people from America, or Ericsson only, recruited in Scandinavia. Maybe Hansen only investigated women. So there's going to be factors that introduce bias into the meta-analysis. So what you do with this test for heterogeneity is check your data to see if there are any underlying variables or biases that are going to skew your results, or maybe even make your data incompatible with each other. So what we want here, so actually here we've got a p-value. And what this p-value represents, basically they do a chi-square test and they calculate the degrees of freedom and all this kind of stuff. It's just statistical tests. But what we want to make sure is that the data is similar enough so that there aren't any biases that can skew our result by putting the data together. And what we want is this p-value, as opposed to what we normally want for the p-value. We want this p-value to be above 0.05. And actually, the bigger this p-value is, the closer it is to 1, the more confident we can be that we're not introducing any complications in the data. Right? So we want the data to be homogeneous, not heterogeneous, if that makes sense. So hopefully that makes sense. It's actually unlikely for the forest plot that you'd get in OSCEs to have that information there, but just for reference. And also, just another thing, just for your information, really, the weight is just the statistical weight. Normally, some studies, because they're bigger than others, might have a bit higher weighting than others. We can see here this study only has 40 people, whereas this one has a lot more. Therefore, this study is going to have a higher weight, and actually the biggest study has the biggest weight. That's all these bits and bobs mean. And obviously, we've got the risk ratio here. Don't be confused if this says risk ratio or odds ratio. For the purposes of OSCEs, consider it the same thing. There are some nuanced differences, which, if you're interested, you can go see the QuesMed lecture where I explain it in a bit more detail.
Thanks for watching. Don't forget to like and subscribe. If you're watching this on YouTube, head to our website to watch the next part. If you're already there, just mark this part as complete.